Mr. Garu, we are live now. Please start.
Thank you, Savan. Ma'am, with your permission, shall I start, ma'am?
Okay, we will start now.
Yeah, thank you, ma'am. Good afternoon, doctor. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your queries in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our eminent speaker, Dr. B.K.N. Sudha ma'am, who is a qualified and had experience of 13 years in practicing and caring in the obs and gynecology. And also she's a consultant and at Sudha Clinic, Hyderabad, and she completed her CAMP and DNB and fellowship in infertility, and also she completed her DGO from Osmania Medical College, and she has done her medicine, and she has done she have won so many gold medals in medicine and surgery. And with this, we welcome you for today's webinar, ma'am. And coming to the today's topic, as we know that ovarian hyperstimulation syndrome is the most serious complication of the controlled ovarian stimulation, as is the part of ART. So while the safety and efficacy of ART is well established, and so one should always aware of the risk of OHSS in a patient undergoing COS. So now, without wasting much time, let me turn over the time to Dr. B.K.N. Sudha ma'am to give a delivery talk on prevention and management of OHSS. Over to ma'am.
Thank you, Dr. Someshwar, for your kind introduction. Today's topic is prevention and management of OHSS, that is ovarian hyperstimulation syndrome. So usually, this is a dreaded complication which can occur very rarely in settings where we do ovulation induction and IUI, but it occurs most commonly in the fertility centers where IVF and ICSI procedures are done. So we should have a good knowledge about this condition, because we may come across a dreadful complication. I'm not able to move myself. Okay. OHSS is the most serious complication in controlled ovarian hyperstimulation for assisted reproductive technology. It is characterized by a broad spectrum of signs and symptoms that include abdominal distension, discomfort, enlarged ovaries, ascites, and complications of enhanced vascular permeability. The syndrome can be strictly defined as the shift of serum from the intravascular space to the third space, mainly to the abdominal cavity, due to the follicular stimulation. In its very severe form, OHSS is a life-threatening condition. So OHSS is an iatrogenic and potentially life-threatening condition that can occur in young, healthy women. So that means purely this condition can be avoided if we follow some protocols and go through the management details. In addition, there is an important economic burden associated with OHSS, including absentee from the work, bed rest or hospitalization, and even sometimes intensive care monitoring in severe cases. So coming to the epidemiology, the frequency of OHSS depends upon the clinical situation, like ovulation induction or ovarian stimulation followed by timed intercourse, or IUI versus IVF. Because in ovulation induction cases, very less cases can occur. And in IUI cases, we give more of stimulation. And in IVF cases, most of the time we come across. And next thing is, when ovulation is induced with clomiphene citrate or aromatase inhibitors, either for timed intercourse or intrauterine insemination, ovarian enlargement consistent with mild OHSS can occur, but moderate to severe OHSS is rarely seen. But in IVF settings, the overall incidence of moderate to severe OHSS in some series was 3 to 6% and 1.1 to 2% respectively. The use of dopamine agonists may also have contributed to decrease in the incidence of OHSS in the last decade. So let us see the pathogenesis of OHSS. So during stimulation, we get a large cohort of follicles developed and they are sustained. And then if we give HCG trigger, massive luteinization occurs. This leads to overproduction of VEGF, that is vascular endothelial growth factors, causing dysfunction of blood vessels. This leads to massive fluid shift from intravascular to third space. And finally, it leads to hypovolemia, edema, ascites, and hydrothorax, causing impairment in the organ functions. And this is a beautiful picture in which we can understand the mechanism. Like we give gonadotrophins and the ovary gets stimulated and oocytes develop. We start picking up the oocytes after giving HCG. So multiple corpus lutea are formed. And this will release vasoactive peptides like VEGF, IL-6, IL-8. And this causes increased capillary permeability, causing capillary leakage. So this, from intravascular space, the fluid will be shifting into the tissues, finally leading to hypovolemia. And this in turn leads to reduced organ perfusion, causing renal or liver impairment. On the other side, it causes hemoconcentration, leading to thromboembolic events. So let us know the risk factors for OHSS so that we can predict in which woman is more prone for OHSS. Previous history of OHSS or PCO, and the potential markers like high AMH or high antral follicular count, and single nucleotide polymorphisms in genes involved in follicular growth. But this cannot be done right now. The risk factors related to ovarian response, that means once we started the stimulation, we can predict in which cases they may go into OHSS. If there are multiple follicles, more than 20, and each larger than 10 mm, or rapidly increasing estradiol concentration, like more than 3500, and high number of oocytes retrieved. HCG given for luteal phase supplementation, and elevated serum or follicular fluid VEGF levels. And finally, if she becomes pregnant in this cycle, she is having more risk to develop severe form of OHSS. And how to diagnose? By history, the time of onset of the symptoms related to the trigger and the medication used for the trigger. Usually, HCG will be the culprit in cases of OHSS. And the number of follicles on final monitoring scan, and the number of eggs collected if it is a case of ICSI, where the embryos placed and how many, and whether she is having PCO. All this should be elicited in the history. And coming to the symptoms, the lady may come with abdominal bloating or abdominal discomfort, pain, she may need analgesia, she may have nausea, vomiting, and breathlessness due to pulmonary edema, and reduced output due to renal failure, and leg swelling due to tissue edema, vulval swelling, and associated comorbidities such as thrombosis, which may be due to hemoconcentration. And once we examine her, we should look for signs of dehydration, edema, which can be elicited in the pedal edema, vulval, and sacral. And heart rate, respiratory rate, blood pressure, body weight, everything should be noted. And abdominal examination, we have to assess for any ascitic fluid, any palpable mass or peritonism, and we have to measure the abdominal girth. This is very important. And respiratory examination, check for pleural effusion or pneumonia or pulmonary edema. And the test we have to do, full blood count, and the hematocrit is a very important marker. If it is more than 40, we can confirm the diagnosis. C-reactive proteins, urea and electrolytes, which show hyponatremia and hyperkalemia. And serum osmolality, there will be hypoosmolality. And in LFT, there are elevated enzymes and reduced albumin. In coagulation profile, there will be elevated fibrinogen and reduced antithrombin. And HCG, this depends upon the timing of the trigger. If it is more than 1 week or so, we can do the HCG also to predict whether she may become pregnant. And ultrasound to check for the ovarian size, pelvic and abdominal free fluid is there. We can consider ovarian Doppler also if we are suspecting ovarian torsion. And the other tests which are indicated are arterial blood gases, D-dimers, ECG, chest X-ray, and CTPA or ventilation perfusion scan. And these tests usually we do if she needs an ICU setup. So classification of OHSS. This depends on the clinical features and also biochemical markers. So let us see in detail. Mild OHSS. Here, she may have abdominal distension, discomfort, mild nausea, vomiting, diarrhea, and enlarged ovaries. So this most of us might have seen the mild forms of OHSS. Here, even if we investigate, there are no clinically important laboratory findings. And the next one, moderate OHSS. Here, along with her symptoms, we can elicit ascites in the ultrasound. And coming to the biochemical features, the hematocrit will be more than 41% and elevated WBC, that is 15,000 or more, and hypoproteinemia. Coming to severe OHSS, so we rarely come across this situation, but we need to know the diagnosis and the management. Here, along with the mild and moderate features, she will be having ascites, sometimes tense ascites, severe abdominal pain, intractable nausea, vomiting, and rapid weight gain, that is more than 1 kg in 24 hours, pleural effusion, severe dyspnea, oliguria or anuria, low blood or central venous pressure, syncope, venous thrombosis. Coming to biochemical features, she may have hematocrit more than 55%, WBC more than 25,000, and serum creatinine more than 1.6, creatinine clearance less than 50, and hyponatremia, hyperkalemia, and elevated liver enzymes. And the last one, critical OHSS. In addition to the above features, she have the multi-organ failure like acute renal failure, arrhythmia, pericardial effusion, massive hydrothorax, thromboembolism, arterial thrombosis, ARDS, and sepsis. Here, all the biochemical findings even still worse as compared to severe OHSS. And coming to other classification of OHSS, depending on the beta HCG, like early onset form, late onset. Early onset, here it occurs due to the HCG administration. So this occurs in the first 8 days after HCG administration. And the late form, this occurs 9 days or more. That means We have already given HCG, and later on she conceived, and again endogenous HCG production will be there. So this may lead to the late form of OHSS. And the other criteria, like other investigators have divided as mild OHSS, the woman presenting with mild OHSS or symptoms, depending on their symptoms, we usually classify them. And moderate, severe, and critical, those presenting with the similar signs and symptoms, again, they can be classified into self-limiting OHSS. That means no catastrophic events occur. She will not go into the multi-organ failure. And the other one is OHSS with significant comorbidities. That means she may go into multi-organ failure, like venous thromboembolism, acute respiratory distress syndrome, cerebral edema, acute ischemia, encephalopathy, kidney injury, and liver failure. And what are the specific complications which we can expect? The first one, ovarian torsion. Due to the heavy size of the ovaries, which occurs in OHSS, there is a risk of torsion, and this can lead to abdominal pain, nausea, vomiting, hypotension, leukocytosis, and anemia. So in these cases, we need to immediately take her up for surgery. And the other one, thromboembolism. These are very rare, but the most serious complication. Again, this thrombosis may be arterial in 25% or venous in 75% cases, and may lead to permanent neurological injury or death. The occurrence of these events is likely related not only to hemoconcentration, but also to hypercoagulation associated with elevated serum estrogen concentrations. In one report, high levels of factor V, platelets, fibrinogen, profibrinosin, fibrinolytic inhibitors, and increased thromboplastic generation were observed in women with OHSS. So, how to predict and prevent and treat? First, we shall go into the prevention part. Again, in this, primary and secondary prevention. Primary means before starting HMG or FSH, that means she has not entered into the risk factor. Secondary prevention means after starting HMG, FSH, she has developed like multiple follicles or so, but before giving HCG. So what are the predictors? So even before starting the ovulation induction, we can guess which set of women may develop OHSS. These are PCOS, young age, and antral follicular count more, and E2 level on the day of HCG, insulin resistance, large ovarian volume, and high AMH levels. But the bad predictors are BMI, genetic predisposition, serum VEGF, von Willebrand factor, perifollicular blood flow. So the same we are repeating, like in young, lean women with PCO, we can expect or predict an antral follicular count more than 10, and AMH levels more than 3.3, and E2 levels more than 5,000, and the number of follicles more than 18. So in some studies, they have found out that there is a relation between PCO and OHSS around 50%. And this is a relationship between the age and OHSS. That means most of the cases occur at around 27 to 30 years of age. And BMI and OHSS, here we observe, in this slide, we observe that the BMI is not a good predictor. There is no good significance. And this slide shows that plasma E2 concentration to predict OHSS. That means if the E2 level is more during HCG trigger Like if the cutoff value we can take is 2560. Above that, we can expect OHSS. And coming to the AMH and OHSS. Here we found out that the cutoff value for AMH is 3.36 and the cutoff value for age 33 years. That means below 33 years, the chances are more. And the BMI is not a good predictor. So how to check this antral follicular count? So we shall do it by transvaginal ultrasound after ovarian stimulation with GnRH agonist and before starting FSH. The follicle size 2 to 5 mm in both the ovaries should be counted. Patients with less than 5 follicles were poor responders. So this slide shows the pictures of how to count for the antral follicles in a vaginal scan. Here we can appreciate the up and the left side picture. The AFC is very low. The middle one is we are able to see some 8 follicles, and in the right bottom one we are able to see multiple antral follicles. So in the third woman, we can predict she may enter OHSS. And AFC versus AMH. Here also it is proven that higher the AMH and AFC, the more chances of OHSS. And these are the curves comparing the antral follicular count and the AMH in cases of OHSS. And coming to the primary prevention. So even before stimulating or starting the ovulation induction, it is better we give insulin sensitizing agents like metformin in cases of PCO and reducing the doses of gonadotropins. It is always better to start with low doses compared to starting with higher doses. And GnRH antagonist protocols will be fetching for us because if we suspect OHSS, we can give them the GnRH agonist trigger instead of HCG. And low dose of HCG or recombinant HCG or recombinant LH. But this is, we cannot accurately say. It is always better to withhold HCG rather than giving low doses. And alternative agents to HCG, that is GnRH agonist, and avoiding HCG for luteal support. Instead, we can use progesterones and in vitro oocyte maturation. Coming to the insulin sensitizing agents. So metformin suppresses the insulin levels and decreases the ovarian androgen production with improved ovulatory rates. So metformin treatment before or during ART cycles decreases the risk of OHSS in PCO women. And this is a beautiful graph which will show that myoinositol also prevents OHSS. And in addition to that, it has so many advantages. Like in the first one, we can appreciate that oocytes retrieved at pickup more in case of myoinositol group compared to placebo group. And in the second one, the number of M2 oocytes is also more. And the number of degenerated oocytes is very low. And the grade 1 embryos are high. And coming to the myoinositol role in OHSS. So according to the study, they have concluded that myoinositol is a promising treatment for the prevention of OHSS in a study done in 2015. And there is a significant decrease in the vascular permeability and significant decrease in the E2 concentration. And the clinical studies confirm the role of myoinositol in OHSS prevention, like rapidly rising or high serum estradiol cases. There will be definitely the lower in the peak of E2 levels at HCG administration if we give myoinositol. And in cases of large number of small follicles, there is a significantly higher number of follicles with diameter more than 15 mm. And the other group of experts, they concluded that the clinical data demonstrate efficacy of myoinositol, B.K.N in the treatment of PCO. These evidences are strongest for the dose of 2 grams twice daily. So here we shall see the dose for myoinositol, like 2 grams twice daily is optimum. And the ratio of myoinositol and D-chiro is 40:1 is optimum. And we have so many preparations in the form of tablets, capsules, but the best one is the powder form, because the other forms can lower the absorption and they can alter the efficacy. And the taste and acceptability is also taken into account. And coming to the Cochrane database of systematic reviews 2011, they concluded that chronic low-dose step-up protocol results in better pregnancy rates with reduced incidence of OHSS compared to high-dose regimens. And the minimal stimulation or natural cycle IVFs will be better to prevent OHSS. And using recombinant FSH instead of urinary FSH has no effect in reducing the incidence of OHSS. So these are important while we are choosing the different forms of FSH for stimulation. And coming to which protocol, like GnRH agonist or antagonist protocol, they have concluded that the use of antagonist protocol was associated with large reduction in the OHSS cases. And the added advantage being possibility of using agonist. That means, let me make it clear. If we use GnRH antagonist protocols, we can use GnRH agonist as a trigger instead of HCG. But in cases of GnRH agonist protocols, we don't have other options for giving the trigger. The trigger of oocyte maturation with a low dose of HCG in high-risk patients reduces the OHSS. There is no evidence of difference between recombinant HCG or recombinant LH or urinary HCG in achieving final follicular maturation with equivalent pregnancy rates and OHSS incidence. That means whatever we give, a recombinant or urinary, that doesn't alter the outcome. The use of GnRH agonist instead of HCG for the trigger results in the lower incidence of OHSS, but extremely high early pregnancy loss due to luteolysis. The disadvantage of giving GnRH agonist as a trigger is this one, the luteolysis. The luteal support will be lost. So to prevent that, what we can do is we can cryopreserve the oocytes, and in the next cycle, like frozen transfer, we can plan. And let us say no to HCG as trigger whenever we suspect OHSS. And this is under study now, the kisspeptin as promising oocyte maturation trigger for in vitro fertilization. So this is a GnRH analog. This is still under the trials. So once we come out with this molecule, I think most of the OHSS can be reduced. And progesterone, HCG or GnRH agonist are used for luteal phase support. But the use of HCG was linked to higher risk of OHSS. So instead of giving HCG as luteal phase support, the other better options are progesterones or GnRH agonist. Progesterone seems to be the best option in the luteal phase support. And in vitro maturation. So this is an attractive strategy to prevent OHSS in PCO patients. Usually for many patients, we won't prefer this because it involves earlier retrieval of immature oocytes at the germinal vesicle stage and followed by in vitro maturation and ICSI. Though promising data on IVM technique has been published, unfortunately, there is still no evidence from RCTs. So this is still under trials, and in future we can expect more of IVMs. Coming to secondary prevention. So once the woman has already developed so many follicles and we are expecting OHSS in her. Now what to do? The options are we can cancel the cycle or coasting, cryopreservation, and intravenous albumin or hydroxyethyl starch, dopamine agonist, calcium gluconate infusion, vasopressin B1A antagonist. So we shall see in detail regarding each one of this. Coming to the first one, cycle cancellation. We can cancel the cycle even without giving the HCG. This is the very effective in the prevention of OHSS because the woman will not become pregnant, and also all the follicles also will not rupture. But this becomes a financial burden and a psychological stress to the patient. Though it may be acceptable in IUI cases, in cases of IVF, it is not practically possible. Coming to coasting. So what is coasting? It is the withholding of further gonadotrophin stimulation and delaying the HCG administration until E2 levels plateau or decrease significantly. So here, this is to be done in cases of IVF cycles. So here we stop the gonadotrophin and HCG we will delay. But there is no evidence to suggest a benefit of using coasting to prevent OHSS compared with no coasting. So it may there may be a little bit advantage, but it cannot completely avoid the OHSS. The other one is cryopreservation. It involves freezing of all the embryos to be thawed and implanting at a later date. So as we have discussed, we can give a GnRH agonist as trigger, we can retrieve all the oocytes, and we can do the embryo transfer in the coming cycles. Early OHSS may occur, but it almost eliminates the risk of late OHSS. Although, even though we cryopreserve all the oocytes, there is chance for early OHSS due to the multiple corpus luteum happen. And the intravenous albumin and hydroxyethyl starch. There is a limited evidence of benefit from intravenous albumin administration at the time of oocyte retrieval in the prevention of severe OHSS. Whereas hydroxyethyl starch markedly decreases the incidence of severe OHSS, and this is a cheaper, potentially safer alternative to albumin. So HES is a preferred drug. Coming to dopamine agonist. So this is universally available, and even for the cases of IUI or ovulation induction cases, we can immediately start this drug. Cabergoline appears to reduce the risk of OHSS in high-risk women, especially for mild to moderate cases. So the dosage will be like 0.5 mg daily for 8 days post HCG trigger. Even if she conceives in the same cycle, there is no risk for the pregnancy outcome. And the other one, calcium gluconate infusion. So 10 ml of calcium infusion of 10% calcium gluconate in 200 ml NS for 3 days post ovum pickup can effectively prevent severe OHSS and decreases OHSS occurrence rates. And coming to vasopressin 1A antagonist. Among the novel therapies being investigated for the prevention of OHSS, this vasopressin V1 receptor antagonist, that is relcovaptan, has been studied for its ability to inhibit VEGF by modulating vasoconstriction and vascular smooth muscle proliferation. So this relcovaptan in the hyperstimulated rat model has shown lower concentration of VEGF-A in the peritoneal fluid and lesser ovarian weight gain. And finally, it reduces the number of corpus luteum. But still, it is in the research stage. It is yet to come. And coming to the summary of all these recommendations, let us see which are recommended. The reducing the gonadotrophin dose and GnRH agonist as ovulation trigger, adjuvant metformin, and cabergoline. These 4 are highly recommended. And wherever possible, the other alternatives are hydroxyethyl starch, cryopreservation, or cycle cancellation. And the interventions which are recommended, like individualized controlled ovarian stimulation, and these are still under research. Like coasting, I have already told you that there are no clinical trials to strongly support coasting can prevent OHSS. And this vasopressin receptor antagonist also still under the trial stage. And once diagnosed OHSS, how to manage, whether to treat her in the outpatient management or inpatient management. So management of OHSS is supportive and admission is reserved only for severe OHSS. Outpatient management can be done in mild to moderate OHSS if the patient can strictly adhere to the treatment and follow our instructions. And inpatients, definitely for the severe OHSS, and to maintain oral hydration, to prevent hemoconcentration, and to overcome the discomfort of abdominal distension and oral analgesia and IV hydration, and even for paracentesis. For all this, we will do inpatient management. Coming to outpatient management, this includes the daily fluid balance. That means daily we have to give her a chart to monitor the fluid intake, and the output also should be measured. And daily her weight should be monitored, and abdominal girth should be checked, whether it is increasing. And regularly blood tests and scans should be done. And coming to analgesia, we can use paracetamol or codeine, but NSAIDs should be avoided because it may cause renal dysfunction. In the outpatient management, for luteal support, give progesterone only, but not HCG. And coming to hydration, she can take the fluids to relieve her thirst, but not to excess. And coming to the activity, so we have to advise her not to go for strenuous exercise or sexual intercourse, because any injury or torsion to the enlarged ovaries can occur. And the blood test should be done in her each visit. The areas that require coverage during outpatient management, we can, if she has ascites, that can be tapped through vagina or through abdomen. And if symptoms do not resolve and severe OHSS develops, she should definitely be admitted. And coming to the inpatient management, we should put this chart in our OPs to check for all these things, like abdominal girth, weight should be recorded on admission and daily. And vitals, fourth hourly. Input output balance should be maintained. Output should be by indwelling catheter. And regarding the blood test, we should check for the full blood count, coagulation screen, urea and electrolytes, LFT daily. And pelvic ultrasound should be done to check for the size of ovaries and also for ascites. And coming to inpatient management, we should target to prevent thromboembolism. That's why we give low dose, low molecular weight heparin. And the other one, maintain hydration by giving IV fluids, preferably NS. And the drainage of ascites to relieve abdominal distension and respiratory distress. And also draining the ascites will help relieving of the pressure on the ureters so that her renal function becomes normal. And pain relief with paracetamol. Let us talk in detail regarding each of this. How to prevent the thromboembolism. So we can add anticoagulant therapy like low molecular weight heparin and dose according to the patient's weight. And coming to hydration, some of the women cannot tolerate oral fluids due to vomitings. So IV fluids, preferably NS. And we need to strictly maintain input-output balance. And regarding the hydration, if she goes into hypovolemia, then plasma expanders like hydroxyethyl starch, 6% solution in isotonic sodium chloride solution can be used at a maximum daily dose of 33 ml per kg. And that too very slow administration to avoid lung congestion. And the albumin dosage is 25 to 75 grams per day according to the severity of hypoalbuminemia and the total volume of ascitic fluid we have drained. But albumin, this should be kept for a later stage once she develops hypoalbuminemia, because this albumin administration, they have the risk of hepatitis, excessive albumin overload, renal dysfunction, and viral contamination. And coming to the drainage of ascites, this can be performed per abdomen or per vaginally. And pain relief with the paracetamol or opiates. And nausea vomiting with the antiemetics. Coming to the treatment of critical OHSS. So here definitely multidisciplinary management should be done in collaboration with the intensivist. So strict fluid and electrolyte management, crystalloids and HES for hydration, IV albumin if required, thromboprophylaxis, paracentesis, cardiosynthesis, or pleurocentesis. All this will relieve the abdominal distension and dyspnea. It also promotes diuresis and clinical resolution. Coming to the management of complications. So she may land up in renal failure, thromboembolism, pericardial effusion, or respiratory distress, which are life-threatening. These conditions should be diagnosed early and managed by a multidisciplinary team in an ICU setup. And coming to the resolution and prognosis, the pathophysiological process of OHSS is self-limited, and the increased vascular permeability regresses spontaneously. That means we need not panic. The mechanism, whatever we have already discussed, will definitely revert back to the normal. But we should not allow her to go into the severe or critical OHSS. Those who have not conceived recover in 10 to 14 days from the onset of initial symptoms, because by the time the action of the corpus luteum also comes down, and thereby the VEGF also comes down. And the third place space fluid begins to re-enter into the intravascular space. Concentration reverses. Natural diuresis occurs. So what are the mechanism? We have told that there is a shift from the intravascular to third space. Again, after 10 to 14 days, provided she is not pregnant, again, they will revert back. Clinical evidence of resolution includes, so how to, how we can, we are happy that she is resolving, like the normalization of hematocrit. So we have discussed that hematocrit more than 40 confirms OHSS. So again, this will revert back to normal. And progressive reduction of ascites on ultrasound and elevation of the clinical symptoms. And also we are monitoring her abdominal girth, weight, and also all those parameters also reverts to normal. If pregnancy occurs, resolution may take longer. As described above, OHSS may worsen the initially as HCG levels rise. Control studies suggested that OHSS pregnancies had a higher rate of miscarriage and later complications such as gestational diabetes and pregnancy-associated hypertension. That means once she becomes pregnant after overcoming the OHSS, so we need to explain that she has a risk of miscarriage or she may develop GDM or preeclampsia. On the other hand, a control study did not show increased fetal or maternal morbidity during the second and third trimesters among women who developed OHSS compared with IVF control patients who had not developed the syndrome. That means there is a split in the opinion that some studies shown that the women may develop these complications. In some other studies, they have compared the women with OHSS and without. They found out that there is no significant increase in the risk. So this finishes the detailed regarding the OHSS, its prevention and management. So any questions?
Thank you very much, ma'am, for giving a wonderful presentation. And it was very honor and learning to hear you, ma'am. And thanks, ma'am, for taking us into OHSS and its various prevention strategies. And from the presentation, we have understood that there are various avenues by which its incidence can be greatly reduced. And this begins with the identification of the high-risk woman through to the woman who is at risk and subsequently initiating the appropriate therapies. Thank you very much, ma'am, for explaining very nicely. So, ma'am, if you allow me, then we'll take the questions.
Okay, we will go through the questions.
Yes, ma'am. Ma'am, we have a first question, that is, what is the role of kisspeptin in prevention of OHSS?
So this is under trial now. So this is a novel peptide. Like instead of GnRH agonist or antagonist stimulation, this may take their part in future. So this can be given once. It need not be repeated as we give GnRH agonist or antagonist. And using this kisspeptin, the chances of OHSS are very less. So this is still under study. There is time so that we get full details regarding this.
Thank you, ma'am.
Yeah.
We have one more question, ma'am. That is hormonal markers in OHSS, AMH or absolute E2?
See, AMH we do even before starting the stimulation. So in that AMH level, if it is more than 3.3 or so, then we can expect OHSS in her. And coming to the E2 levels, usually in IVF setups, we do E2 levels before giving the HCG trigger. So in that means I want to say that AMH and E2, they are done at different timings. Like both of them can predict the OHSS. Like higher level of AMH more than 3.3 or E2 level more than 2,500 or 3,000 also can predict the OHSS. So that we can be at caution.
Thank you, ma'am.
Okay.
Ma'am, we have one more question. How we can judge the one particular case will have OHSS?
So the predictors for OHSS, we are told that a young lady who is lean, who is having PCO and who is having high AMH, and if she have a past history of OHSS, all these are the predictors, like more antral follicular count. And during our follicular monitoring, if we come across many number of follicles, like it depends on the treatment. Like if we are planning for an IUI cycle, usually we target 1 to 3 follicles, dominant follicles. So if we come across more than 5 or so, then we can predict OHSS in her mild form. And in cases of IVF cycles, if the follicles, dominant follicles are more than 20, then we can definitely predict she may land up in OHSS.
Thank you, ma'am. We have one more question, ma'am. Step up or step down, which can reduce the OHSS?
Definitely step up can reduce OHSS because we start with the low doses. So once we come across all these things like more number of follicles or high E2 levels, then we can definitely stop at that particular level of the gonadotrophin. In case of step down, we start with the higher doses. So once she lands up into the risk factors of the OHSS, then we cannot go back. We need to take other options, like already we have discussed, like coasting or cryopreservation or other modalities we need to depend on. So definitely step up protocol have less incidence of OHSS.
Yeah. Thank you, ma'am.
Okay, welcome.
I think there are no more questions, ma'am, from the delegates. Yeah, ma'am. We have one last question, ma'am. What are the secondary prevention methods?
See, secondary prevention means already she has developed the risk factors like so many number of follicles or high E2 levels. Everything is there. Now we want to prevent OHSS. So the options here are whether we are doing an IUI cycle. It depends on whether we are doing IUI cycle or IVF cycle. Suppose we are doing an IUI cycle. Here the best options are we can cancel the cycle. And we advise abstinence for her because they should not have sexual intercourse to prevent the risk of the ovarian torsion or also to prevent the pregnancy. So here the best option is a cycle cancellation, or if we don't want to cancel the cycle, we can go for a GnRH agonist trigger instead of HCG trigger. But the chances of luteolysis are there. So we have to support her luteal phase with progesterones, or sometimes this cannot be overcome. But in cases of IVF cycles, if we want to go for secondary prevention, the best thing is to collect all the oocytes and do cryopreservation and then transfer them in the coming cycles, like frozen embryo transfer, rather than transferring in the same cycle. And also, we have discussed about the cabergoline, like 0.5 mg, we can give it daily from the day of HCG trigger. So this can be given in the IUI or IVF cycles.
Thank you very much, ma'am. I think there are no more questions from the delegates, ma'am. If you allow me, then we can close this webinar.
Okay.
Yeah. Thank you very much, ma'am, for the wonderful presentation and kind support. So we look forward for your continuous support, ma'am. And I also thank all the delegates for their active participation. And many thanks from the SHIELD team. Yeah. Thank you, ma'am.
Thank you. Yeah, thank you, Sheel, for giving me this opportunity. Thank you.
Yeah, thank you.
Thank you, ma'am. Thank you very much, Madam Garu.
Okay, thank you. Yake Garu.
Thank you, ma'am.